Hey, I'm Kyle Cousineau. I'm here to present my poster about my research on orthodontic management of SMMCI. My PI was Dr. Joseph Cheever. So yeah, let's get into it. So, introduction, our solitary median maxillary central incisor syndrome, also referred to as SMMCI, is a rare disorder affecting 1 in 50,000 live births. The disorder describes a presentation of a singular central incisor located directly in the midline of the maxilla. It can be in both deciduous or the permanent dentition. And the tooth is not a mesiodens, not a supernumerary tooth. It's just a single central incisor that's occurring right there on the midline of the maxillary dentition. It can be isolated. Sometimes it's associated with different other diseases and disorders. People with with SMMCI also express other characteristic features like a heart-shaped lower lid, poorly defined philtrum, high labial position, palatal suture malformation, narrow maxillary arch, absence of labial frenum, incisive papilla. We don't really know what the exact etiology of this is, but this unique presentation still requires a uh, different approach when we're treating patients with this orthodontically so that we can resolve the problem that they have. So that's kind of what the objective of this research was, to review other case studies and literature that talks about this disease and kind of summarize different ways we can treat this. So methods, we searched using PubMed, Google Scholar, and Medline, using different adjectives and synonyms to get that search to yield some of the results we need. So you can see here in that bottom left corner, that's what it looks like for the central incisor, just one large tooth there. And then we've got some examples of the treatment and the finish we're going to go over. There's really two major ways that we treat this. We can either open up space um, by extraction of that tooth and then use the other teeth to disguise or camouflage. That's what we see in the bottom left corner. In the upper right corner, we see an example of opening up more space for an implant or any sort of other restoration, bridge, crown, anything to fill that space. So those are the two major ways, and then within those ways, there's different modalities of treating these patients. So the first one we're going to go over is like in that bottom left, is that extraction to open up space and then close the space. So it's through space closure is how we treat it in this case. So, they have a really large tooth. So some people are saying, and that tooth is pretty ugly to begin with. Let's not keep it or have to do excessive IPR to make it look like a typical central incisor. Instead, let's just chuck it. Let's get rid of it, and then we'll close that space. So that's what they did. They extracted, and then they added some buildups that would eventually replace those crowns on those laterals to become bigger and look more like central incisors. Canines were then moved towards the midline and subbed and added buildups to look more like laterals, and that's how they closed that space that they opened up to the extraction. You can see that they got a really good result when they did this, and this is kind of helpful for, they don't have to wait till they're 18 to get an implant or some sort of permanent restoration. They can just fix the problem now, solve it, be done with it, and we're good. So that was a really interesting and unique way, because typically most people end up opening space for a second tooth to be put in, not take that one tooth out. But that helped us solve the problem immediately. So other ways that we could do it are opening up space. Now, what that always will entail, like I just said, we'll have to wait till they're 18 and then get them an implant, bridge, or anything more permanent. We can do like a Maryland bridge for the time being while they're a teenager until they're old enough and done growing to get a more permanent restoration. But that definitely comes with its drawbacks there and having to wait. So typically they have really narrow arches. So this patient was treated with an RPE. So they wanted a rapid palatal expander so they could open up space and not only fix the narrow arch, but also get more space for that restoration that they needed for that second central incisor. Um, Often these RPEs fail due to premature fusion that occurs because of this disease, because it affects all sorts of things on the midline. One of those is the mid-palatal suture. So those RPEs typically fail, and you end up just getting dental alveolar movement rather than skeletal expansion. But in this, they got at least they got the expansion they needed through dental alveolar tipping, and they were just able to create space for restoration and a Maryland bridge, and then eventually implant is up to the patient what they want to do later. Next one we got is premolar transplantation. So in this situation, they were also able to resolve the situation relatively quickly. They didn't have to wait till an implant later, because as soon as they opened up enough space, they just took one of the lower second premolars and put it up there where the central incisor belongs. They then contoured that tooth and added buildups to make it a little bit more representative of the central incisor, and closed everything. Once they were done, closed all the residual spaces. So that's another great way that they can solve this, is through auto transplantation. So that way they don't have to wait. Another interesting one was osteogenic distraction. So like we mentioned earlier, a lot of these RPEs fail because of that premature fusion of the maxillary suture, so what their palatal suture. So what they needed to do in this situation was they went in and used surgery to open up that suture that the RPEs, they had 2 RPEs that failed to open it. So they got a surgery to open it, and they ended up getting a Lefort 1 performed, and then also used some osteogenic distraction to more correctly position the maxilla. And this distraction was carried out with a custom Hyrax screw distractor, and they slowly activated 2 millimeters of activation over the course of 2 weeks. So after the space opening, the fixed appliance orthodontics were carried out, and they were able to get everything closed up and close the space that they created with the restoration. So we can see in the upper right hand corner, this was that second case that we went over, where they just added a Maryland bridge for now after they opened up space with the tipping of the expander. And now the patient's looking pretty good with 2 normal looking central incisors rather than that median central one. In the future, we need to do some more studies to assess why that palatal suture fuses, when does that fuse, and figure out the best timing for expansion, because if that's the case, maybe we'll be able to see, hey, once we diagnose this in a young child, let's get that expander in at a younger age, maybe 4, 5, 6, I don't know, to determine if we can get that skeletal expansion before it fuses. So studies to figure out when the sutures fuse would be great. Maybe it fuses before birth or right at birth, and we can't really do much about it, but finding that timeline would be great to help us fix these with correct skeletal expansion and not need the surgery like in that final case. So our conclusion is the management of solitary median maxillary central incisor syndrome presents unique challenges due to its rare presentation and association with midline developmental anomalies. The reviews highlighted various orthodontic treatment strategies, including space opening for prosthetic restorations, premolar transplant, and space closure with restorative modifications. The choice of treatment must consider the patient's age, occlusal relations, and psychosocial factors, as well as potential for premature suture fusion and alveolar bone atrophy. Really important to think about all these things when we're treating these patients. Some people just need something now. If you're having psychosocial factors where you're getting bullied at school, maybe the kid needs something more permanent now, so you can just take care of the problem and be done. In that case, the extraction with the space closure and buildups would be great, rather than having a space open for a long time with a Maryland bridge that might not be super stable, or a retainer that has a flipper piece with the pontic in it. Just getting a more permanent thing and getting it taken care of now might be great. Also thinking about bone atrophy, we might have that bridge in for, if we're treating the patient at 13, we might have to wait 5 or more years to be able to get an implant, and we don't want the alveolar bone to atrophy in that area where they'll no longer be suitable for an implant in the future. So things like premolar auto transplantation are great, or just the space closure right away would be great too. So multidisciplinary collaboration is crucial to achieving both functional and aesthetic outcomes in patients with SMMCI, and future research focusing on long-term outcomes and advancement in treatment modalities will further enhance our understanding of the management of this complex condition. So really complex, interesting condition that requires a lot of input from other docs. That's my research. Hope you enjoyed it.